Hannah. I'm from the Academic Health Science Network, so I'll be chairing this group. So just obviously as you're the first speaker, Tommy, just so you have a heads up of what I'm going to do at the beginning. So I just have like a little like message to read out, and I have a couple of things that we'll just follow in the group. So just obviously to let everybody know that it's recorded. If they could, we'll use the Q&A section to ask questions, and then innovators can respond. I have asked that people address the innovator or use the company name so we know who the question is directed to. They might not always be asked in the actual sessions. And then also, I think, is it 10 minutes you've been given to speak?
Yes.
Yeah, so we'll do 10 minutes. So then 1 minute before the end, I'll like prompt you to let you know that there's 1 minute left till the end of your 10 minutes. And then we will do a couple of minutes Q&A, and then we'll move on to the next speaker.
Okay, perfect.
So once we're in the Q&A, I will ask the next speaker to sort of get their slides ready, not to share them, but so they're just ready to share the second that the Q&A finishes. And then I'll just introduce as we go on. And yeah, I think that's about it. So I've got to wait for people to join the room now. I know that talk's gone on a little bit over, so yeah.
Yeah, no, I can imagine. And can you see my slides as slideshow and changing slides as well?
Yeah.
Okay, excellent. So at least we know that that's working.
Yeah. So I know that you've provided like a little bit of a blurb about what the company's about for the agenda. Did you provide that, or has Pete prepared that himself?
I provided that to Pete.
Right. Yeah. So obviously I was thinking, do I read out the blurb for the speakers? But I thought that's just going to take up extra time. And I'd rather you have the time to be able to talk about the company. So I'll just introduce you as name and company name.
Yeah, that's perfect. Yeah, I'll be able to yeah, it's basically an extension, a deeper version of what's in the kind of brief blurb anyway. So
yeah, great stuff. Hi everyone who's joining. We'll give it till 10:05 just because I know that previous call ran over, so we'll just give everyone a few minutes to jump over. Has anybody been to an online event like this before? It's quite intense, a lot of speakers.
I don't think I've been to one that's quite this full and packed of just, I think there's so much going on, and I'm looking forward to some of the recordings, definitely, because I think there's lots going on all over the place that sounds really great and could be really beneficial, actually.
Yeah, definitely. So. Yeah, I think it is good because it's all been uploaded to YouTube. I don't know if you knew that, but all of these recordings will be uploaded to YouTube afterwards. So obviously people can't attend every talk as they may want to. So yeah, it'll be good to be able to just go and watch them after that. And then yeah, you can probably watch them in a bit more detail as well, being able to watch them on YouTube, as opposed to in the moment you're trying to concentrate and take information in and write notes maybe and all this stuff. So yeah, it's good. We'll just give it 1 more minute, and then I'll do a quick introduction, and then we'll let Tommy get on with his PowerPoint. Oh, somebody shared the link to the playlist that will be coming with all the recordings on, so thank you. Right, I'm sure other people will come in as we're talking, but we'll get started just because I'm conscious of time, and at the end of this session you have a little bit of a break, and I don't really want to eat into that because the next break is only for 10 minutes. So We'll just get started. So I'm Hannah, I'm the Sustainability Project Manager at the Academic Health Science Network for North East and North Cumbria. So good morning, everyone. I hope you are all looking forward to the day ahead, as we have just talked about. It's very intense and a lot of information to take in, but this group is themed around models of care. So within that, we'll be covering digital platforms, patient consent and cancer detection. So before we do just get going and get into the presentations, I'd like to just cover a few housekeeping things. So we are recording all sessions. So if I could ask for those who don't want to be recorded, if you have your video turned off, obviously with it going on YouTube, I appreciate people want their faces to be plastered all over. So more than happy for you to turn those cameras off. As it was explained in the very first session, we do encourage people to obviously ask questions about what they're hearing. So if you could do that under the Q&A tab along the top toolbar, that would be really great, because then we just have an easier way of monitoring those questions and they don't get lost in a chat. Also, when you are asking questions, if you could include either the name of the innovator or the company name that the question is directed to, it just means we can make sure the correct person is answering and you can get the right information. And as I've just mentioned, we encourage questions. We also encourage networking and collaboration. So if you would like to connect with anybody outside of this event, please do share your email address in the chat, and then we will know that people are allowed to contact you. I will prompt speakers when they have 1 minute left to speak in time, and then we will close 5 minutes before the 15-minute session is up that is allocated to speakers to allow for questions. So that's everything from me. So I'll pass it over to Tommy Parker from KiActiv. I think, is that right?
Yeah, spot on.
Yeah.
Thanks very much,
Crack on,
Hannah.
Tommy, you've got 10 minutes.
Excellent, thank you. So yeah, I'm Tommy Parker. I'm the CEO at KiActiv, and I'm also a fellow on the NHS Innovation Accelerator. And at KiActiv, what we're doing currently is providing a new model of self-care to improve health outcomes within the NHS. And the way in which we're doing this is by rethinking exercise and helping to make people's everyday physical activity a medicine. So what this means is that we've developed a personalized, technology-enabled, mentor-guided digital service to empower sustainable behavior change for physical activity and all of the impacts that that goes along with. Our focus is on helping people to optimize their personal physical activity dose. So rather than just thinking, again, like exercise in small kind of particular doses, we want to look at someone's whole lifestyle and enable them to think about how they can optimize physical activity in the context of their health, capacity, and environment. And what this does within the system, because physical activity is obviously a core part of health and well-being and a lot of particular pathways within the NHS, this can help to transform the access and delivery of exercise services for both the prevention and management of long-term conditions, but also to improve access and outcomes from rehabilitation services. And so how does this translate into supporting the NHS with their net zero goals? Well, there's three key areas for us in terms of how our digital solution can help to positively impact on the emissions side of things within the NHS. And so the first is around reducing unnecessary healthcare travel. So that can be from reducing visits to A&E, it could be reducing reliance on kind of GPs, but it also might be taking care outside of that current healthcare setting. Through our behavior change, we're also promoting active travel choices and giving people both the kind of physical and mental confidence to be able to take up those opportunities. And we've also been able to show that by improving self-care, we can reduce medicines. So what does the current system look like in terms of physical activity? Well, as I've said, it's a vital aspect of both prevention and management of long-term conditions and is the cornerstone of rehabilitation pathways. So it currently exists within the system within a number of places. But traditionally, the services have always been made up around structured exercise. So that's really bringing people into healthcare facilities, leisure facilities, fitness facilities, and giving them a period of exercise, typically 1 hour a week for 6, 8, or 12 weeks, depending on the program that there is. And obviously that creates a burden of travel. People are having to get into the system. And the other aspect of that is that that not only has the emissions impact, but it also has an impact on access and uptake, because it does create a barrier, and a barrier that also disproportionately affects people from lower socioeconomic backgrounds. The other aspect of the issues around these services in terms of being kind of difficult to take up and often unengaging for people, there's a lot of us out there who don't like exercise or the word exercise, and so those offers can be quite off-putting, and we see that typically across the UK, uptake to rehabilitation services around about 40 or 50%. So if you think about that in real terms, 50% of people who have heart attacks who should be going on to have cardiac rehab aren't, and we need to find a way to solve that, because that poor uptake and engagement and completion is also leading to a higher burden on the system. It's leading to greater readmissions and greater healthcare utilisation, all of which have a carbon footprint. And so KiActiv is looking to overcome those challenges. So we're improving outcomes, inequalities and emissions and delivering that impact at scale. And so just to give you kind of an overview of how this relates to and how we can improve on the carbon footprint. The first aspect is really about providing a proven and accessible digital alternative to current rehabilitation services. So as I said, there's quite a poor uptake nationally across a number of different pathways. The barriers to those are quite well known and quite well evidenced, and they do include things around kind of travel, the burden of getting to the facilities, and that creates a clear opportunity to be able to do things digitally in people's own environment. By empowering self-care and improving outcomes, we've also been able to prove that we can reduce hospital and emergency admissions, as well as reducing the burden on GPs, so reducing GP visits as well. And we can improve people's functional capacity, confidence, and motivation to also choose active travel methods. And then finally, because physical activity has an impact on so many long-term conditions and rehabilitations, we can also reduce the prescribing that happens. And you may have seen on the previous slide that, in the context of kind of the NHS Carbon Footprint Plus, that travel makes up around 5% of emissions and medicines makes up about 20% of emissions. And so these aspects, which are all kind of outlined as well in the Delivering a Net Zero NHS strategy document, are real opportunities for us to have a tangible and quite significant impact on carbon emissions. So just to think about how that plays out, we can increase the capacity of services for physical activity without the associated emissions. So without the travel to facilities, without people, needing to be there in a facility that also has a utilities aspect. We can reduce the amount of visits that are needed into healthcare facilities. So again, reducing those emissions. Enabling active travel is going to have a further impact, and obviously medicine reduction will too. And so at this point, you're probably wondering, what is KiActiv? So we've talked about kind of the role of everyday movement. And so the other three aspects are components within our digital service. We provide everybody with a physical activity monitor that measures the intensity of their movement every minute of the day. And this enables us to capture a really comprehensive picture of people's physical activity, and then display that back to them in the KiActiv dashboard to help them build an understanding of where they currently sit, but also all of the opportunities they have to change within their very personal and unique lifestyle. Because not everybody wants to choose the same ways to be active, and we don't need to. That's the beauty of physical activity. When we boil it down to what physical activity is, it's any bodily movement that increases our energy expenditure. So it doesn't have to be exercise in the way that people have thought about it, and this creates a huge amount of opportunity for people to change. And by employing self-determination and other proven behavior change techniques, we can ensure that people choose to change in a way that's going to work for them in the long term. We also provide a personal mentor alongside the service. So this enables people to get the most from the technology. This could just be supporting with some of the basics to ensure that we're able to provide digital access to as many people as possible, but also includes motivational interviewing techniques to enable people to make real progress on their own. And in terms of impact, what we've seen is that this has been really well received, but also been able to demonstrate some really strong measurable impact. So we have a very good completion rate. Our age range is very broad, and we've been able to demonstrate outcomes in a particularly aging group. And also we've been able to show that we've got a representative picture of the most deprived 20%. So again, helping inequalities. The key findings box really here just outlines some of the evidence we've shown around reducing medicines, reducing GP appointments and hospital visits, and the underpinning patient benefit that we've seen in terms of improving physical activity, quality of life, self-efficacy, and mental well-being. And on the right-hand side, you'll see a quick quote from somebody from a cardiac rehabilitation pathway that highlights the kind of myriad of benefits ultimately that physical activity can have, and in particular here, reducing the dose of opiate painkillers as well alongside their cardiac rehab. So we've been working in 10 ICS regions across a number of different primary, community, and secondary care pathways. And what we've been doing is been able to kind of push and empower that self-care in order to improve care outside of hospital settings, and as we've talked about, the impact that that can have on admissions. So within Gloucestershire, for example, a lot of the data I just showed on the previous page relating to reductions in medicines and also the reductions in visits to GPs and hospital, they are outcomes from that particular programme working in primary care, proactively supporting long-term condition management. And we've also then been able to demonstrate how that has reduced readmissions. We're also working with Bath and North East Somerset Council on a particular programme called the Active Way, which is one of the social prescribing and active travel pilots funded by the Department for Transport. So again, highlighting how active travel can be an important part of delivering a net zero NHS. Just
want to remind you, Tommy, 1 minute.
Perfect. Well, I'm on to my last slide now, so I've managed to time that quite well. From our perspective, we're now looking to increase the adoption of scale of our service across the system, helping to transform pathways and meet those NHS priorities goals, whether that's Core 20+5, net zero, or just aligning to the long-term plan. So I look forward to any questions and hopefully speaking to some of you about having that impact in your region moving forwards. Thank you.
Thanks, Tommy. So if anybody has any questions, feel free to either raise your hand and you're more than welcome to ask them talking, or if you want to pop them in the Q&A tab and Tommy can pick those up. Are there any questions? I don't think so. So we can maybe make a few minutes back. Tommy, just keep an eye out in the Q&A or I'll tag you in them. And we can move on to our next speaker, who is Katrina from Ufonia. Katrina, do you want to just test your slides are working?
Yeah, I'll just get everything up now.
In the meantime, Tommy, you've had a question in the chat.
Gotcha.
I'll ask the question out loud. Is this for specific patient groups?
So really, we're focused on working anywhere that physical activity has a clinical impact. So it does fit quite a broad patient group. So it's either people who are kind of have a number of risk factors for disease, have a long-term condition, or are going through rehabilitation pathways. So it pretty much spans diabetes, cardiovascular disease, musculoskeletal. We're doing a lot of long COVID work at the moment. So it's really anywhere that physical activity plays a role.
Thanks, Tommy. Just in the interest of time then, any other questions Tommy will respond to in the chat or in the Q&A panel, and I'll monitor those and make sure that he gets sight of all of those. So I'll hand it over to you, Katrina.
Brilliant, thanks so much, and thanks everyone for coming to today's group session. So I'm Katrina Mason, I'm a clinical lead at Ufonia, and I'm also an ear, nose and throat surgeon in London. And what I want to do today is explain what our technology does and to present our ongoing carbon modelling work to date. Can everyone see the slides okay? Yeah, fantastic, thanks. So essentially, our vision at Ufonia is to increase capacity in the system through automating telephone conversations as a like-for-like replacement for clinical interactions. We do that by combining artificial intelligence and clinical evidence, and we do it through our platform DORA, which is a UK CE accredited technology. I think the best way to sort of understand our technology is to do a demo. So hopefully this will start working.
Good afternoon. Good afternoon. This is Dora, the automated assistant from Stoke Mandeville Hospital. Is this Mr. John Smith speaking?
Yes, it is.
Hi, I'm calling to follow up after your cataract surgery. Would this be a good time to talk?
Yes, that's fine.
So, I've just got a few simple questions about your eye. Has your vision improved as you expected since the surgery?
Yes, my vision has got a lot better, and I'm happy with the surgery.
Good. And since the operation, have you had an increase in floaters, small dark dots, squiggly lines or cobwebs in your vision?
Perhaps just one or two floaters, yes.
And these floaters, are they new since the surgery?
Yes, they started a couple of days after the surgery.
Could you tell me more about the floaters and when they started?
A couple of days, 2 days after the...
So I think that just gives you a little bit of a taster of what the technology is. So essentially we're replacing those interactions of human clinicians with our patients via sort of an AI conversation. So coming on to sustainability and our interest in that, and essentially our interest in our carbon footprint and our potential impact of our technology started back in 2019, and we formally collaborated with the Centre for Sustainable Healthcare. And that was actually through an Esperi Healthcare Net Zero grant to help us look into this. So the first task that we did was to accurately carbon footprint our innovation, Dora, so that telephone call that you've just heard. And then we moved on to model specific conversations, and we started with a head and neck cancer triage conversation, which was my main project. And then we've sort of expanded this into modeling the carbon impact into all of our conversations, and we're primarily doing that in the cataract pathway. So the first thing we did was, what's our impact from our technology? And we calculated that that telephone call that you've just listened to has a carbon footprint of 0.43 kilograms of CO2 equivalent per phone call. That's primarily made up of server use, but with a little bit of input from patients' smartphone use, and also when the report comes into the clinical team, reviewing of that clinical report. So intuitively, if you're replacing a face-to-face consultation with an AI telephone solution, you've got potential carbon savings, and we think those in four main areas. So we can reduce patients coming into hospital. We can therefore reduce the staff that need to come into hospital to have those interactions. We don't need to use any single-use plastics or any consumables that you would traditionally use in a face-to-face consultation. And we can also reduce hospital energy use because you're not seeing anyone face-to-face. So we used various methodologies to help accurately carbon footprint our solution and potential solutions. And essentially we used a sort of hybrid technology of bottom-up processes and EEIOA techniques. So as I mentioned, our first project was a carbon modelling of the head and neck cancer triage conversation. And what this photograph represents is all of the single-use plastics and consumables that I, as an ENT surgeon, would use in a consultation with a patient to assess whether they have head and neck cancer. And I think just that process of carbon footprint modelling my consultation was incredibly powerful. And I think it's really invaluable as a clinician because it really visualised how carbon heavy some of our processes are. So translating that into carbon saved. So what we found out was the Ufonia's technology was over 200 times less carbon heavy than a standard consultation. And I think when you start to upscale that and model that into, that's a single conversation, what's that like if we translate that to all the conversations that you can have in a particular trust, or if we roll this technology out nationally, we can be saving tens, if not thousands, of CO2 equivalent annually. So obviously we've got conversations in real world use. So we're looking at our cataract conversation, which is live in about 10 trusts in the NHS at the moment. And what we now do, because we've accurately modelled these technologies, is we can give a sort of accurate carbon savings. And this is, I think, a really nice sort of estimate that we're saving at least about 300 kilograms of CO2, and that's just from a single conversation. I think the sort of potential impact of all the other conversations that we have and would like to develop is huge. I think one of the things that the companies is doing, which is really nice, is that we're actually regularly reporting back to the trusts and the HNs who have bought our technology. And in our reports, as well as providing sort of the cost savings and actually the data breakdown of what we're doing, we now formally include a carbon savings so that the trust or the HSN can get feedback in how much carbon that they're saving from the technology that they're investing in us. So just to summarise all of that, essentially what we did as a company is we acknowledged that this was really important for us to do. So we formally collaborated with experts. I think that's, that's important. I'm a clinician. A lot of our company is engineers. And if we want to have credible data that is meaningful, you have to get an expert on board. So that's what we did very early on. We've formally carbon footprinted our technology, and therefore we're formally estimating the savings that we are making to trusts, and we put that in a report back to our trusts. I think Pete wanted us to put an ask out for our groups, but just very simply, I've put my contact details there. So anyone who's interested in our work, please do get in touch with me, and I'm happy to provide you more data or just talk you through the process that we went to help sort of carbon footprint our technology. A bit under time, so happy to take any questions. Thank you.
Thank you, Katrina. That was great. And thanks, I didn't have to do any prompts. So at the moment, there isn't any questions in the chat or under the Q&A. So if anybody wants to actually ask a question, please feel free to pop your hand up. Somebody's put their hand up. So Tim, if you would like to ask your question.
Hi there. Sorry, I did try to put one in the Q&A, but it didn't seem to have come through. And I'm a little bit unclear. Perhaps you could just explain a bit further how the DORA platform, Katrina, how it replaces face-to-face appointments, because I can see how it could replace a staff telephone call, but then how does it do anything above a staff telephone call, human telephone call, in order to prevent appointments? That bit's just not quite clear.
So I think we understood that actually a lot of the clinical interactions that we have as clinicians is simply a conversation. Yes, we can do examinations, but actually, the majority of our conversations are conversation based. So that's what we're replacing. We're not replacing face-to-face examinations. We're not replacing sort of procedures, but a lot of our consultations per se are actually just communicating. So that's what we're replacing. We're not replacing the other side of clinician interacting.
So sorry, just to follow up, so how does that differ from just having a staff member phone a patient?
So in terms of just a simple telephone call replacement, so the only thing is we're replacing that telephone conversation. But what we're trying to do is a lot of the conversations we're replacing are traditionally face-to-face. So we're going not one jump, we're trying to do two jumps in one, as it were.
Okay, thank you.
Thanks, Tim, for that question. Second, Anna.
Just, I think, following on from that question, how do you, I assume there's a process for capturing those that need to be followed up from that conversation, and do you have a staff member dedicated to review that for each place? How does that work? How does that part work?
So every conversation will have an output in a PDF form that gets sent back to the clinician. So each clinical conversation has been sort of co-created with the clinical team who want to replace that clinical communication. We've approved a report format. So it might just be the simple like yes, no answers. It might be a calculator. And essentially that just gets inputted back into the electronic system. So a bit like a sort of letter or a PDF report, and a patient gets a letter of the conversation as well.
Amazing. Thanks, Katrina, and thanks, Anna, for that question. I have those questions. I've put them under the Q&A tab, so there's like a written record of them, and I am adding the answers in to those as well from what's been said in this presentation. So thank you, Katrina, for that. That was great, and it's great to hear about DORA. You have as well allowed us to get back to a bit of punctuality, so I won't blabber on a bit too much. We next up have Dr. Mahapatra, is that correct? I don't want to pronounce it wrong. Yeah.
Yeah, it's Piyush, Mahapatra.
Yeah, from Open Medical. So do you want to check your slides work when sharing?
Yeah, absolutely. Perfect. Is that projecting okay?
Yep, I can see that. So I would like to assume everybody else can. So I'll let you crack on.
Fantastic. Well, good morning, everyone. As mentioned, I'm Piyush Mahapatra. I'm Chief Innovation Officer at Open Medical, but I'm also a consultant orthopedic surgeon and an NHS Innovation Fellow. And I think, so the only reason I sort of put this slide up is I also have a couple of industry roles with the ABHI. And I think when we're looking at things like models of care and net zero, having that holistic approach is really important. I think industry has a big part to play, as well as the clinical side, both at local and at national level. So I'll discuss some of those in a bit more detail, but I'm going to start with a bit of around our sustainability vision, then how technology can help deliver sustainable models of care with a few examples of that, and then how we can actually try and embed that going forward so it becomes a business as usual type process. So who are Open Medical? Well, our overriding mission is to achieve sustainable healthcare for everyone through digital excellence. And we do that through our PathPoint platform, which is an enterprise level cloud solution that does patient pathway management. So it's very much clinical workflows, clinician facing, and manages that entire patient journey. In terms of UK footprint, we're in over 150 sites with more than 3 million patient pathways now processed in the UK and Ireland. And this is an example of an end-to-end journey. So this particular one is in surgery. And again, it goes all the way from initial referral or even GP consultation down into discharge and patient reported outcomes and remote monitoring at the downstream end. And with regards to our sort of sustainability offering, that's really built around 3 foundational elements. First is measurement. So can we allow real-time measurement capability of carbon footprinting within clinical pathways? So that again is fairly unique technology. We want to try and then use that to promote sustainable decision making, and that could be directly again at the coalface with a clinician in mind, so making them make more sustainable choices. And then finally using technology as an enabler, and again a lot of those are very well known, things like digital letters, remote consultations, etc. So what does that really mean in practice? I think the problem is obvious, and I won't dwell on this too long. I'm sure everyone here knows the inherent challenges in current models of care. So whether that be pathway complexity, large volumes of patients waiting, and very disjointed and fragmented processes. And clearly that can have impacts across various different domains, from energy to pharmaceuticals to supply chains, etc. So what we're trying to do is, can we use technology to sort of refashion a lot of these existing care pathways to have more sustainable solutions going forward? So our virtual fracture clinic solution is our class leading sort of model of care. It's used very widely across the UK. And this is just an example. I won't go through it in detail, but really patients end up seeing their minor injuries units with a fracture that then is referred to a virtual fracture clinic where triage decisions are made. And we're seeing now more than 50% of patients do not require face-to-face appointments. And so this is traditionally patients with broken bones that are actually being treated entirely differently. And that what the technology has allowed with improved governance and transparency is actually different clinical decisions to be made. So there's a lot of research being done. Patients are now not given plasters as much. They're given removable splints, again, to try and enable that care delivery without having to be seen face to face. So as I said, there's a lot of downstream changes. And again, our approach is always around a transformation component and then having technology to enable and facilitate that. So these are real world impacts from one particular site, and you can see the numbers there. I won't read them out, but again, huge carbon savings, whether that be through patient travel, reduce paper use, reduce consumable use, etc., etc. So, as I said, using technology can have real-world benefits. Moving towards a different pathway, and again, this is something that is very topical now around elective surgery and the increased move towards regionalized surgical hubs. Again, the challenge now lies if you're centralizing services, you want to try and minimize patient transport as much as possible. Can you deliver things like preoperative assessment closer to home? Can you risk stratify patients so you use resources appropriately for those patients that really need it, and you conserve resources where a light touch approach would be better suited? So again, technology allows you to do that risk stratification, and that then promotes a more sustainable care pathway. And that sort of feeds into our three main pillars. So if I'm doing a little bit of a deep dive into our elective surgery pathway, we can now have the technology to calculate carbon costs in real time across that entire surgical journey. So what I'll show you there is an example of a digital anesthetic chart. So you can see here that the patient's had a general anesthetic. This was the cost of that event, including an individual drug level. So this is something that we appreciate is continuously evolving, and the data is not perfect at present. We're reliant on existing literature and research work, but we're hoping the drive to more transparency, both within the procurement process, is going to then make this data more accurate, more reliable, and be benchmarked against the same standards. And that's where the industry component becomes really important. I think everyone needs to be aligned, and industry needs to help contribute towards this data to try and make this as fair and transparent and clear as possible, so people do make the right decisions. So extrapolating that forward, you can see that there is, in elective surgery, again, there are massive savings to be had through the use of technology if you model out a sustainable surgical pathway versus the current standard of care and scale that forward. You can see that there are massive savings to be had. And again, this is not particularly complicated technology, but it's about reimagining the model of care around to be the more sustainable, and then layering that technology on top. And finally, so my third example is going to be around dermatology. Again, this is something we do fairly widely across the NHS. And really, this is about community-based diagnostics. So the move from hospital-based care into a community setting has massive benefits. And what you need to make sure that happens is reliable technology. So this is an example across East Kent, where we're really targeting coastal communities. So you can see the central dermatology site is quite some distance away. And again, it's about being strategic and focused about where you deploy your services. With new cloud technologies, again, you're not limited to facilities. So you can be very creative on how these are used. And in particular, what we're seeing is we can often address a lot of other secondary areas. So health inequalities very closely link. And you can see here we've very much targeted coastal communities in order to improve their access to care, target health inequalities, which also then has a major downstream benefit for the environment as well.
Sorry, just 1 minute reminder.
Perfect. So how do we make that, how do we embed that across the NHS and make it business as usual? So, I very much advocate for a systems thinking approach. So try and be holistic with how you decide technologies and what they're used for. make sure you think about the workforce. That's, most of us now realise the pressures that people are under, and provide improved transparency and governance, as well as some of the other benefits I've mentioned there. So, as I said, it's a final sort of take-home message. It's important to measure your impact, make sure that is used to promote sustainable decision making, and try and do that by design so it's fully integrated, and promote those practices and continue to promote them going forward, and really embrace technologies as an enabler, but make sure you've targeted those models of care first. So thank you very much, and do please get in touch if there's anything that you think we could do to benefit your models of care work, or provide any advice. Very happy to help.
Thank you, Dr. Piyush. So I just want to give an opportunity for people to ask questions. So if anybody has any, please raise your hand or pop it in the Q&A chat function. I don't think there's any questions at the moment, but if you, as I say, if you want to pop them in the Q&A function as time goes on. Oh, someone's put one in. Let's have a look. So the question is, have you done anything on the maternity pathway? Also said it was such great work.
Thank you very much. Yeah, that's very kind of you. So we have done a little bit of work that was more around the acute side of maternity, so induction of labour scheduling, how to optimise that process. We haven't yet done the community side, so that was more secondary care focused, and that was more of an operational solution rather than necessarily an environmental. But as I sort of alluded to, quite often we do see, if you can improve scheduling, improve transparency, it actually does have a lot of those secondary environmental benefits, because they all sort of go in together. Anything high cost, high time will invariably end up running a high environmental burden as well.
Thank you, Dr. Piyush. Is there any more questions? Nope. So I'll pass those on to our next speaker then. So we have Michael from Procomp Health. So Michael, if you want to just test that your slides work when you share them.
Yep, great, no problem at all.
Yep, I can see those. Hopefully everybody else can. If anybody can't at any point see the slides, by the way, please just raise your hand and I'll check that out. But yeah, please proceed, Michael.
Brilliant, thank you. So morning everyone, thank you very much for the opportunity of speaking here today. It's quite an important thing for us to have a forum where we can start talking about not only the impact that technology and innovation can have within healthcare globally, but also the impact it can have on the climate as well. And that isn't often taken as being a key agenda item with a lot of procurement departments. And it's also massively, well, we found from a historic perspective, quite often overlooked as being a benefit and not necessarily an additional cost. But when procurement sort of does their scoring and everything else, sometimes that sustainability box just isn't there. So be very interested in other people's presentations today and experiences from there. So if I can give a quick overview of Procomp and what we're going to show today briefly. So Procomp is a company that was created to look at clinical pathways, and predominantly to look at the measurement of those pathways. But quite quickly we found from the UK, and also we're in the US as well, is that typical sort of large EMR type patient record systems aren't innovative, aren't flexible, and don't really deliver on the front line in the way in which staff want to interact with patients. So we spent the last 4 or 5 years building a platform that allows us to quickly deploy in a number of different environments in any speciality. And the key thing really is we work from a bottom-up approach. So we get staff onboarding quite quickly because we allow staff to almost tailor the way in which they want the system to run. So it's a platform. It has all the usual accreditations for being secure and everything else in the UK and the US, but it's a platform, almost a toolbox that allows us to sit down with staff, sit down with trusts, identify and map out exactly what they're trying to do, and then put usually quite simple systems together, but are quite revolutionary as far as staff is concerned, because it actually allows them to interact with patients in the way they want to, which has been a traditional problem with sort of big IT and a lot of patient record systems. So we work in the UK, US. We also now work in Guatemala as a full service provider, right the way through from primary, secondary and beyond. And that's all about replacing a very traditional paper-based system with lots of people running around, lots of admin, with a complete digital solution. So that's a project that we're working on over the next year and a half. So what I want to show you today briefly is a project called Pact. And this very much was a Bob ICS project. So we were very lucky in the fact that we could actually have a full audit of the solution post going live. And the key thing here is about working within pre-assessment. So Oxford University and the Nuffield Orthopaedic Centre had a couple of key challenges that they put down on the table. So everything from managing waiting lists, which is a very popular issue at the moment, but more so about actually redesigning the way in which they do pre-assessment on patients. So the idea being here is that rather than when you come in for an appointment and you get listed for an elective procedure, rather than going away, coming back again for different tests, going away again, trying to sync all that in, at the end of the listing, you actually spend an extra hour in the clinic and you do a lot of the tests there and then. The issues with that is having the staff available to understand the tests and also having the consultants available if there's complexities. But that's something that we built into the system. So the challenge is there. We're increasing the pool of patients who are fit for surgery, which is very key at the moment. Personalizing the optimization, so what tests are right for what people. And also key thing there is only testing the people that actually need testing. Which was a big indicator for them because they were spending a lot on repeat tests, either due to time in coming in for appointments or to the fact that they weren't sure what had happened before, so they had to redo things. Digitization, it was really key. And also a key requirement was carbon footprint as well. Supporting wider staff to run the service was really important as well because there's a higher band nurses and that was proving costly, but also restrictive in what they could actually do. And the other big ask was obviously integrating back into the EPR at the end of the day. So if you imagine a typical sort of solution or a typical scenario there where patients coming back, what I'll do, I'll give you a quick overview of the solution and exactly what we did at each step. So as I said, the patient gets listed for surgery, and rather than the patient going away and awaiting for another appointment, what we asked was, could the patient hang around for another hour and a half? Was that okay? We didn't have any major pushback on that whatsoever. When we explained it would reduce further visits. So what we did then was provide the patient with a tablet, and they sat down for about 15 minutes and filled in a number of data points that we wanted to collect. And I'll go through those in a minute. Following completing the tablet, the system then basically created a list for the day with all the different tests that the patients needed to go through. So this is everything from whether they needed bloods, whether there was any comorbidities that needed further attention, basically the full list of any tests you could have at pre-assessment was all digitized with some intelligence behind it to rank them as being a high risk, low risk, and what needed to be done with the patient on the day. Two outputs from that really. One was either the patient needed further tests, and that was roughly about 25% of patients who needed that, but that was accommodated quite easily and very focused. The ones that didn't need any more tests were put on the waiting list. and then typically they have their operation, and then they're into sort of rehab. So go in a bit more detail about exactly what we did at each step. So on the tablet, the key thing here was to have a PROM, which is a key indicator for pre and post as an outcome, health screening questionnaire, occupational screening questionnaire, consent, permission to follow up. The whole idea being here is that once we get the patient on a digital engagement, we're then able to talk to them multiple times all the way through the pathway. And that's what really allows us to monitor and to manage the patients and to get any more information off them if we need to. So following the information we collect on the tablet, we then had the staff then allow them to recommended tests that the patient needed to go through, record the results on the system, and then basically recommend what the next steps were. So whether it was a face-to-face, further tests, whether there's any issues and everything else. So that was part intelligent, part expert system. But again, working with the staff members to make sure that it worked for them. And I think that's a key thing with a lot of these solutions, is if you don't get the champions and the staff on board, it becomes a top-down approach and becomes prohibitive. So if further tests are needed, then that was booked with the patient. But the majority of patients who went on the waiting list, we then had the opportunity to monitor them, check on their condition, refresh any information we needed, and also do check for change over the phone, which is a 10 to 15 minute conversation, which basically allows for a staff member to ensure that that patient hasn't had any change in their condition prior to them coming in for the operation. And the operation, basically, if it's elective with hips and knees, for example, there's implant scanning. So we have an operation model as well, which we do a lot in the US at the moment, and that's being rolled out for this project as well. And then post that, there's a PROM follow-up for the outcome, but also there's the help and support as well. So health, exercise, how to look after your wound, et cetera, So basically, we're closing the loop and created a new workflow with the staff. There was a lot of brainstorming with the staff about how this could work and what some of the key issues were with the existing solution. And we managed to nail all those and to roll that out. So as part of sort of the green agenda here, and again, we were very lucky here because we've been trying to get away independently, and it's always difficult for a supplier to be able to say, hey, we're going to save you X, Y, and Z if it isn't independently verified. So with this particular project, we were very excited that the York Health Economics Consortium was doing a full report for the NHS under the innovation guidelines. And basically, they were looking at the entire process, all the different impacts. And later on, I'll share a link where you can download the full report because there's lots and lots and lots of numbers in there. And I wouldn't even dream of trying to do that within this time span. But basically, we're looking at a 769 save per patient, only for the first 1,000 patients, because that's what we do the first report. So it's a significant cost saving in working this way with a small change to the process, but also removing all the admin of chasing patients up and making sure they're fit for surgery. So reduction in face-to-face time and appointments, preoperative testing, so applying the right tests to the right patients and dipping your toe into that personalized care has got a lot of cost savings and carbon savings, and we're a big advocate of that, and using technology intelligence to work out exactly how to deal with that patient efficiently. And also the improved patient management admin, there was no massive reduction in calling, a massive reduction in admin for patients chasing, for staff chasing patients. That was already removed as well. So we saw a reduction in cancelled surgery, and that's growing at the moment quite dramatically. And also a larger range of staff are available to run the service proactively because we're reporting back on exactly where that patient is through the pathway. If we have any greens to ambers or ambers to red, then staff just deal with that from an exception basis rather than trying to go through all the staff's information and pull that out. The green benefits for this, as per the report, so we saved 51,500 nearly kilometers in patient travel time over the average pathway. We saved 8.8 tons of CO2, and that, believe it or not, is 9 return flights from Paris to New York, which we were quite surprised at. Paper and postage costs are obviously a huge one. And also as a company very early on, we decided to go with a hosting company in the UK that does 100% renewable energy. So as far as we're concerned as a IT and innovation provider, we're already ticking the boxes and not putting a huge burden on any of our clients as far as their existing CO2 burden is concerned.
1 minute
So
reminder,
just to wrap, yep, no problem at all. So just to wrap up, as I said before, there's a WIAC report, which I put in that link below. There's also an Oxford NHN report, and also we got put onto the NHS playbook as a best example in innovation within pre-assessment care. So that's another interesting read again. Again, all these are independent. We give them full access to everything we do and how we run. So it's very refreshing to have independent organizations review the impact that this kind of approach has within healthcare and approve some of the green credentials as well. So thank you very much for that. And any questions or if you need to contact me, please do.
Thank you, Michael. That was great and a really great digital innovation. So as Michael said, he's happy to take questions. So if anybody has any questions, if you'd like to put your hand up or in the Q&A section. I have just checked and there was none there, but I did that before, and when I went back there was actually one.
There's one question from Tom. Yeah, so Tom, when the patient fills out the questionnaires on the tablet, they are then automatically put into the staff app. So the staff app, which we designed with the staff members, basically they wanted to see exactly what tests that patient needed, if there was any comorbidities, and exactly what they needed to do next. So within the app, which I'm more than happy to give you a demo of another time if you'd like to, but the app, once you click on the patient, it has all the different tests they need to do. It records all the results of the different tests. And then as that information builds up, there's some intelligence then that tells them if they need to do more or less. So we work quite heavily with their existing process to understand that. And they're starting to see efficiencies now with not having to do as many tests on patients, which is where some of those cost savings come in. So all the information is digital. We still upload to their Cerner system as both PDFs and data as well. So there's a lot of utility in the data, and we can customize it to exactly how each different member or consumer needs to see that.
Thank you, Michael. Is there any more questions? No. Okay, so obviously people are free to carry on putting questions in the Q&A section if you want to just put Michael's name or Procomp so that he knows the questions are directed to him. Now, I did just check. Oh, Mark's on now. I was checking to see if you popped up and there you have, you've just appeared. So Mark is our next speaker from Procomp Solutions. Do you want to see if your slides are working, if you try and share them?
Yes, please.
Yep, I can see those. If anybody else can't see them, please raise your hand and then we will try and get that sorted. I think so. Everyone's okay. No one said anything. So, yeah, Mark, over to you.
Excellent, thank you. And thank you, everyone. So I'm Mark Russel-Smith. I'm Director of International Operations for Procomp. We're a Finnish company and we specialise in AI, artificial intelligence powered optimization solutions. And my background is a frozen road across the sea in Finland, if you're interested. So it gets quite cold in Finland sometimes. So what I want to talk about is delivering care to people in their own homes. There's a massive logistics problem with over 500,000 domiciliary care workers in England, according to Home Care Association, or Skills for Care, actually. And then an increasing emphasis on care at home, for example, virtual wards. And then the workforce capacity crisis is just worsening, it seems. And on top of that, the domiciliary care workforce in the UK drives 1.5 billion miles a year, according to Home Care Association. That's 4 million miles a day. There are only 250,000 miles of road in the UK, so they're literally driving like crazy all over the place. And this is often overlooked in net zero plans. So changes are needed, but what changes? So how to increase capacity, efficiency, quality, or staff satisfaction, or how to get virtual wards and integrated teams to work effectively or meet net zero targets, for example. But it's a really complex problem, and some of the challenges for key decision makers are, well, the extreme complexity. So you have an array of services which are delivered by many providers with a huge workforce. And all of this needs to come together so that all these workers can travel around to be in the right place at the right time to give care to people in their own homes. And then there's often poor data quality as well. And all this means it's very difficult to even understand what's happening at the moment and get good insight into the current performance of the system. And details just get lost in KPI reporting. And on top of this, then it's even more difficult to identify the changes that you'd need to make and implement to bring about any improvements to the system. So this is where Procomp can help. So we develop AI-based optimization solutions originally for the logistics sector. And our largest logistics customers optimize around 400,000 shipments a day using our systems. And 75% of retail food distribution in Finland is planned and optimized with our systems. And then we started working with domiciliary care in Finland in 2011 when we saw that it is a logistics problem. The right person needs to be in the right place at the right time. But then, of course, it's quite different to delivering a parcel. So a lot of work has gone into adapting our systems and what we do for domiciliary care. And we've delivered over 80 domiciliary care projects. And we work with about a third of the Finnish domiciliary care workforce and many integrated teams in Finland. So we're working with health and social care. And this year, we were selected for the NHS Innovation Accelerator Programme, the NIA, which is it's very good to be part of that. And when people think of optimization, they usually think of operational optimization and using software for the daily planning of services. And this is something that we do, but perhaps even more important is strategic optimization. And strategic optimization is a technology, AI-powered service, which we've adapted from the logistics world. And it enables informed decisions to be made. And we do this by taking a snapshot of operational data, and then we can model multiple scenarios to evaluate changes. And it avoids the need to run multiple live pilots. And it also means that you can evaluate bigger changes, which would be difficult to pilot in the real world. So things like large structural changes, for example. And another benefit is it enables transparency and dialogue. So it gives really great insight into the current ways of working and performance. And then when we do the modeling, it enables really good dialogue between all the stakeholders. So everyone can see the effects of making changes when we do the modeling, and they can see the effects of those changes on themselves and on other people. And then it provides really actionable results. So when we're doing the modeling using R2, it's not just like an Excel exercise where you calculate numbers, but we're modeling and generating actual routes and schedules to show how and what to change. So we factor in traveling, all the skills and preferences and work patterns and all of these types of requirements which are important when you have different services and people traveling around delivering care. And we use quite readily available data, so it's easy to get started. And once we've done the strategic optimization and people have agreed on the changes to take forward, then it provides a really solid base to start actually implementing those changes. And our first projects in the UK after completing 70 projects in other countries, so now 80 in total at the moment, was with the Academic Health and Science Network in the west of England and together with the southwest. And this was a strategic optimization project, actually 2 projects. So looking at some of the results and the work done in that project, first of all, this is looking at how working practices affects the workforce utilization. And in this graph, you can see the bottom is the load, and the top shows the available capacity, actually the number of care workers working at that time of day. And you can see in the morning there's not much headroom between these lines, which means the workers are rushed and there's not enough time for travelling. Whereas at other times of day, between about 9 in the morning and 8 at night, there's a lot of headroom between these 2 lines and there's a lot of unused capacity. So modelling was done to see what changes could be made to unlock some of that capacity and also reduce mileage. So this resulted in changes to care assessment practices, brokerage, managing client expectations, and also some changes to the IT systems, which were rather rigid. And this is very interesting work we did. I think one particular problem in the UK is that the domiciliary care system in particular is highly fragmented, and you have many care agencies working in the same area, which I think people intuitively know is inefficient. So in this case, we took data from 6 providers out of about 60 in the area and representing 60% of care packages. And this shows how the care workers from those 6 providers were travelling around. So you can see it's quite a mess. And these are just the routes for a single day. We show the routes as the crow flies for clarity. But we modelled what would it look like if you were to have a more consolidated approach. So here we have 3 consolidated areas. So mileage is reduced by 65% and 35% fewer care workers are needed each day. So it makes significantly better use of the workforce and significant reduction in mileage. And this is with only 60% of care packages. If you would have 100% of care packages, the results would be even stronger. So this shows that you can achieve significant reductions in mileage and carbon emissions by making these kinds of changes without having to invest in electric vehicles. And it also enables more walking rounds and more cyclists, for example. And as a result of this, local authorities are looking at changing their commissioning practices and committing to carbon reductions for domiciliary care. Another theme which we're not going to be looking at in the IHSM projects, but many of our international projects over the last couple of years have been to do with getting integrated teams working effectively. So what we see is that integrated teams are often integrated in name, but not in nature. So the operational planning of the different services and professions is still very separate. But there can be benefits to implementing integrated planning. And this means sharing tasks between practitioners from different services, and also taking advantage of the fact that sometimes different services have different requirements for the timing of their visits. So it enables you to level out the peaks and the troughs in demand in different services and make better utilization of the workforce.
1 minute reminder.
Okay, thank you. And again, in strategic optimization in this kind of scenario, it really enables transparency and dialogue between the professions and the services when you're modelling changes to shares of responsibility, for example. And here's one example from Finland, integration, a strategic optimization project from Rovaniemi, and integrated teams had 11 care assistants and 6 registered nurses in each. And it was found that the number of registered nurses needed could be reduced by 50%, while still leaving those registered nurses with enough time to handle unplanned events. So thank you for listening, and my contact details are here if you'd like more information and to discuss. I'd be very happy to hear from you.
Thanks, Mark. Great presentation. And there's a couple of comments in the chat, and I think I can echo them as well, that the mapping of the routes was a very strong visual, especially when you can see the comparison, and it's a clear comparison from an intervention. So yeah, really, really good. So you do have one question that's already been put in. So the question is, do the consolidated routes require different care providers working together to pool and then assign routes and visits?
So the consolidation can be done in different ways. It can be by purely consolidating, or by having care workers or care agencies cooperating. We're looking at how to the best way to shape the market back in that direction to enable this. I think sometimes care providers are quite keen to cooperate once they see the potential, if they would do so. But yeah, the consolidation could be done in different ways.
Thanks, Mark. I also just want to give anybody else an opportunity to ask any questions. So if you want to either pop them in the Q&A, the chat, or put your hand up. Don't think there's anything at this time, Mark, but obviously just to keep an eye out on the Q&A just in case anything pops up. And thank you for that. So we'll move on to our final speaker. We do have an extra comment in the Q&A, but I will pick that up at the end because it's about a presentation that we've already had. So if anybody has any questions about presentations that we've already had, if you want to pop them in, and we'll address those at the end of the presentations. So moving on now, we have Lise from Walk with Pape. Are you able to share your screen and slides? I think she's in the chat. I can see her there, but I don't know if she can hear. Oh, there she is.
Yes, I'm here. Hi.
Sorry, I was thinking, I'm sure she's in. I've seen her name.
No, I was just looking for the unmute button, but yes, I will go ahead and share my screen. Just 1 second. You see the screen?
Yep, I can see. Hopefully everybody else can. If you can't, please just raise your hand and we will try and get that sorted.
Perfect. Thank you so much. So yeah, my name is Lise Pape, and I'm from a company called Walk with Pape. We're working to protect and enhance mobility and motion, as well as the environment. So our solution is based on instrumented insoles with sensors embedded, as well as a patient-facing app and a clinician-facing dashboard. So the problem that we tackle is called peripheral neuropathy. This is a lack of sensation or an inability to feel the feet. It's common for people with diabetes, but it can also be caused by aging and a multitude of other scenarios. Due to the fact that you lose sensation on your feet, you also lose the ability to feel the ground during walking. And this causes instability, fear of falling, and social isolation, and specifically a poor balance and 20 times higher risk of falling than ordinarily. In people with diabetes, it also causes wounds and amputations. In terms of the scale of the problem, we know that 25% of people with diabetes will go on to develop an ulcer. And that's largely driven by peripheral neuropathy and other things, including blood flow. In the UK, there's 185 leg amputations every week. And globally, someone loses a leg every 20 seconds who's living with diabetes. The cost of treating diabetic foot ulcers is about 1 billion each year in the UK, so it's significant in terms of the healthcare budget. And treatment also carries a major cost to the environment because it's a wound, and it generally, for 50% of people, it takes a 12-week period to heal. For some, it takes longer. There's also a lot of disposables used in this process, as well as travel to clinic. So the global warming potential is nearing 1 million for ulcers that penetrate bones, joints, or tendons. So our solution is around diabetes remote monitoring. So essentially, we have developed these smart insoles that people will wear in their shoes, and they're tracking some of the biomarkers for ulcer development, which is centered around tracking pressure on the plantar side of the foot, as well as temperature changes, which can be indicative of inflammation. Based on those parameters, we can send alerts to the smartphone that the user will have, so they will be notified if there could be a problem which they wouldn't ordinarily be able to feel. Let's say if you develop a blister, for instance, due to pressure or some rubbing, you wouldn't be able to feel that with neuropathy. So this can actually alert you to this matter. And then a clinician is also notified if there's a significant alert. So based on this, the system can provide detection and prevention of diabetic foot ulcers, which can in turn lead to fewer amputations. It also provides detailed out of the lab monitoring and therefore the alerts that come in real time that somebody might have an ulcer risk. And this is expected to reduce or remove some of the need to travel to clinic. And lastly, this reduction in ulcers will also lead to a reduction in disposables used during the treatment of the wound. In terms of our team, we're multidisciplinary across clinical, engineering, and business. We also work with a range of people within the NHS at the moment with Richard Lee in NHS Royal Free and with Neil Reeves in Manchester Metropolitan University on diabetes. So we have just completed an SBRI project phase 1 for the net zero goal. And here we worked with UCL partners as our HSN, NHS, and Intertech. Intertech was helping us with some of the evaluation around our net zero impact and also the impact we can have on reductions of disposables and travel. So we went on to develop a health economic model with UCLP, which will be further developed later on, as well as a commercial model. And we also have been doing a feasibility trial with the Royal Free Hospital and a carbon analysis assessment with Intertech. Some of the findings include that the global warming potential is 8 to 16 times higher with current care and development of ulcers than 2 years of insole usage. The biggest environmental impact of our system on the insole is the initial production of the insole and the charger. So that is something we can look to address at one point. Community teams will be key to prevention and keeping patients out of the acute settings. We also saw in the healthcare economic model we have so far that for every £1 spent, 20 is expected to be saved based on the uptakes we project. And also we did some PPI analysis where we found that 80% of patients would find that regular in-person foot checkups can be disruptive to their lives. And 80% also believe that remote monitoring could replace some of the regular checkups. We're now building a proposal for phase 2, where we want to extend the work we've completed in phase 1. So we want to work more on the health economic model. We also want to further the commercial model and the business strategy. And then we're looking for 2 other trusts to join us in this process. So we will continue working with the Royal Free Hospital, but we'd like to invite 2 other trusts. And we're currently in conversations with some, but we're also looking for others. So if anyone on the call would be interested in joining this, we would love to hear from you. We further want to advance our carbon analysis assessment with Intertech across different scenarios and settings, such as the rural scenario, where London is obviously the more city scenario we've looked at so far. And then we want to look at our insole development to reduce carbon footprint and make a plan for that, as well as further PPI work is also planned both with clinicians and patients in terms of co-design. So the expected outcomes for this will be that we'll be the first carbon validated solution for diabetic foot ulcer prevention. We'll have a clear strategy for NHS adoption. Hopefully, this is something that is in the making. And then we'll have feasibility data across the 3 sites that we hope to work with in this phase 2. So on this last page is just my email, and I would welcome any questions that might be from the audience. Thank you so much.
Amazing, thank you, Lise. So I did just put something in the chat very quickly relating to the 2 other trusts that you're looking for. I'd definitely be happy to help support source another trust in the North East region, so it'd be great to connect after this.
Great.
So any questions for Lise? Just looked and I don't think there's any in the chat at this point. And none in the Q&A. We are still on here for another 10 minutes, so if you do think of any further questions for Lise directly, then please feel free to just drop them in the chat or on the Q&A. So as we do have a little
Great.
bit of time left.
Yeah, sorry, how can I get in touch with you, Hannah?
I've put my email address in the chat. It's somewhere in there, but I will send it in again at the end of the meeting.
Okay,
so
perfect.
it's like fresh at the bottom.
Thank you.
So just to go through a few questions then that were left retrospectively. So we did have a question earlier on from Anna about Mapp. So Anna, I hope you're still here. But the question for Mapp. So is Michael still on the call as well?
Yep, still here.
Yeah, perfect. So the
Coffee's
question
working.
was, how long does the process of building the personalised part with staff usually take, or does it vastly depend on particular place and need?
We've done things within 2 weeks, right up to so our model is, so we're not trying to push it as a sort of a product. It's very much a service. So one of our core USPs is we will evolve as the pathway evolves. So if and with the example I gave on Pact, we've probably evolved that about 10 to 12 times, and even just asking a different question, changing the order of something. The team here is very responsive to doing that because, as I said before, we've built up the platform over many, many years. And it's all been about really quick turnaround of functionality. So rather than putting in a change request, waiting 4 months and all the rest of it, obviously in line with governance, which we fully comply with, we think that if you can't be reactive to the latest requirement, there's not much point in actually doing it. And that's where technology really does start falling apart and not really standing up, especially within healthcare, because as staff start using new methodologies and new ways of working, they're going to come up with more ideas that they may not have thought of at the start. So we will always try and get something in place as quick as possible, because that's been probably the fastest way to get in the right product in the earliest time, if that makes sense. So it very much is a case of, let's get the initial flow, let's build something, let's start putting patients through it, let's get some feedback, and it's kind of that reiterative model. And that's what we found globally as being the best way of deploying these kinds of solutions, because otherwise, when you've done your requirements and you start someone developing something, for example, by the time they come up with something in 6 months' time, it's already changed. So we'd like to say we're probably the most reactive technology platform that works within pathways. And definitely that's what our clients are telling us at the moment.
Thanks, Michael. Anna, I hope that has answered your question. So a couple of questions that I put in myself in the Q&A, and everybody else, please feel free, if you have any questions as these questions have been answered, to pop in, then do so. So this is to all innovators. Hopefully you're all still on the call. So I just wanted to ask those who their innovation involves a digital dashboard or an app that would have a patient management aspect. How do you address those without access to smartphones? So thinking about the older population, low socioeconomic populations, and those deep end populations that, I know we're not supposed to say it, but hard to reach. So yeah, any of the innovators, if you would like to address that. Yeah, Dr. Piyush.
So I think it is really interesting, and I think this is where some of the models of care are really important, that you need to have a model of care that caters for your entire population, and digital can't be the only option. The digital can help facilitate those people that aren't able to engage digitally. So we, for example, create lists of non-responders, and again, work with organizations to specifically target that cohort and set up a process and a digital workflow. So the clinicians can still use the digital solution, but the patient doesn't have to. And what we found really interestingly is actually some of the digital solutions with regards to the health inequalities piece they do actually help. So that dermatology use case I gave, and the coastal communities, we found that the new model is preferred by people with a higher IMD, so a deprivation index as a baseline. Our hypothesis is because they're often self-employed, or they may not be able to take time off work, and it's easier for them to access a community facility. So I think technology can still be used, but you do need a robust process that caters for everyone.
Yeah, no, that's great. I completely agree. I just thought there might be other people with that same question. So again, final one from me to all innovators. What have been the biggest challenges that you've faced becoming a net zero business? Obviously, this is quite a new trend, if you like. It's definitely been there in the background simmering away, but the recent push and the urgency for it has brought this to life in a very new way for a lot of people. So I can't imagine challenges have been really explored. So it'd be good to hear any challenges that today's innovators have faced on becoming a net zero business. I don't think anybody wants to answer.
Yeah, I can probably put some comments on that one, Hannah, if it helps. I think the key thing really is one is doing it for yourself, and with any business commercially then is understanding the value of that investment from your client's perspective. So I think one of the things that I mentioned earlier on, it's not that too long ago before procurement actually asked if any of a sort of innovators or suppliers had any green credentials. So I think it's partly to do with the investment that the business has to make, and then how do you then recoup that investment without adding it to your price line, which is particularly sort of unfair in a competitive environment. But I think now, globally, the sort of the green agenda is starting to become more and more higher up on people's priorities. So there is definitely a change over the last 8 to 12 months, where for some of the bigger contracts or some of the bigger health organizations, they're asking you to demonstrate independently a lot of the times, do you have the green credentials? Are you sustainable? And we just add into the problem that we've already got, that your system's trying to solve. So that's our experience.
Yeah, no, that's really good insight, and it is true, isn't it? When you're thinking about the range of businesses, so small, medium enterprises, as opposed to large enterprises who you often see signing up to big net zero organisations, like becoming B Corp certified. They can afford like all the consultancies, the full life cycle analysis of products and services and things like that. And then you think about those little startup companies, the little small businesses who are just ticking over. And it's like you say, it's about the investment, and it is a competitive market out there, and you don't sort of want to take the legs from underneath you before you've even started. So no, that was a really good insight. Does anybody else have anything to add to that? No, so I think we are actually bang on time for this session. So everyone, there will be other talks that you can join. I know we have the round tables on over lunch, but also equally, you have 30 minutes now to take a break, I think. So it was great to host this session and to hear from all of the innovators. And I hope everybody just really enjoys the rest of the day, takes a lot from it and information. I will put my email address in the chat again. So anybody who would like to contact me outside of this, please feel free to do so. I don't know if I mentioned earlier, but I do represent the North East and North Cumbria branch of the HSN. So if you are looking to like stretch out and make some connections up north, then please do get in touch and we will see what we can do there. So yeah, I hope I've answered everybody's questions in the Q&A. I think they will be formulated and sent out as a resource. But yeah, apart from that, thank you everybody and enjoy the rest of the day.
Thank you very much.
Thanks, Hannah. It's really,
Thank
really
you.
great, great session.
Yeah, thanks Anna, thanks for being so engaging. I don't want to leave until everyone else has left.
Well, I'm sort of supposed to be helping support you, but I think it's probably
Oh,
I think people are, which yeah. So I think there's 2 of us, isn't there, for each session? But I think these people are probably not actually here, are they? Potentially.
maybe not. I don't know if I can do anything remotely. I don't think so. I don't know what on hold means.
I think it might be that they're on another call or another thing. Anyway, I will leave, but I might just whip Emma a quick message.
Oh, we can remove people.
Oh, can you?
Yeah, so I'll just go through and remove. Just so that we can round the recording up, that's all.
Yeah, brilliant. That was great. Thank you.
Thanks, Anna. And so, I'm so sorry because I didn't, 1 second, let me just remove everyone. I didn't realise that you were my sort of facilitator almost.
Well, no, I think I was just there to try and help. You're the facilitator. Very helpful because I'm on another one later on the afternoon. So
yeah, no, I'm
always nice to see how someone else has done it. Yeah, yeah.
Yeah, no, perfect.
You were great and fully in control.
Thank you. No worries. Well, enjoy your break and I'll see you this afternoon.
See you later. Bye.
Thank you. Bye.